For more than a decade, Farxiga, dapagliflozin, has been trusted again and again and again. Now's the time to choose Farxiga for your patients.
Farxiga.
To view clinical and safety information and see what makes Farxiga different, visit farxiga-hcp.com.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, CardioNerds. This is Claire Cambron, and I'm here with Rawan Amir.
Hi, everybody.
And Dan Ambiter.
Hey, everyone. Super stoked to be here.
And we are so excited to go over a really excellent case with our team from New York City, Queens. We have Dr. Ayan Purkayastha, Dr. David Song, and Dr. Justin Wang. All right, so I'm going to turn it over to our amazing team to introduce themselves before we get started on this awesome case.
Hey everyone, I'm Ayan Purkayastha. I'm one of the first-year fellows here at NewYork-Presbyterian Queens. Originally from Massachusetts, did my residency at Brown, and I'm interested in general cardiology.
Hey everyone, my name is Justin Wang. I'm originally from Texas. I came here and did my internal medicine residency at NewYork-Presbyterian Queens, and I'm interested in interventional cardiology.
My name is David Song, one of the first cardiology fellow, born and raised in Seoul, South Korea, came to New York City, did my internal medicine residency at Elmhurst Hospital in Queens, and now interested in pursuing career in general cardiology.
All right, team. Now, can you take a CardioNerds to your most absolute favorite location on the face of this planet so we can get started?
So everyone, we're chilling here today in the heart of downtown Flushing, in one of our favorite hot pot spots, Dongqing Laozhao, only the best hot pot in all of New York. We're conveniently located near some of the best cuisine in the country, so it's only fitting that we discuss our case over some delicious food.
All right, guys, I already gained 5 pounds listening about the food that we're gonna have to eat today. So we're so excited. Why don't we get started with this case?
All right, so today we have a 53-year-old female with a past medical history of hypertension presenting with chest pain. She notes that her symptoms started suddenly 2 days ago at home, and she described her pain as a heaviness radiating to her left shoulder. She also endorsed having shortness of breath and dizziness. She described her chest pain as 8 out of 10 in severity and noted that it was on and off with no clear aggravating or alleviating factors. Patient's only home medication was atenolol. She denied any family history of cardiac disease. She denied having any smoking history or alcohol and substance use. Her vitals and physical exam were unremarkable. Her initial EKG showed a dominant R wave in B1 with decreasing amplitude across the precordium and T wave inversions in the precordial leads. 2 separate troponin levels drawn 1 hour apart were within normal limits. Her pro-BNP was 219. Her LFTs were mildly elevated with an ALP of 118. The rest of her Chem7 and CBC were unremarkable. Her lipid panel was notable for a total cholesterol of 211, LDL of 129, and an HDL of 70. Her A1C was 5.4%. Her chest X-ray showed dextrocardia. Justin, can you tell us about your approach to this patient with chest pain?
Sure thing, Oyan. So chest pain is probably one of the most common questions and consults that we get asked as cardiologists. When evaluating a patient for angina, the first thing I look for is to see whether or not the description of their pain sounds typical or atypical. This patient's symptoms, with chest heaviness radiating to her left shoulder area, is more on the typical side. Next, looking at her risk factors, I see that her LDL is 129, which does put her at an increased risk of CAD. Perhaps the factor in evaluating patient symptoms that comes into play here is her Guyanese ethnicity. We're so lucky to work in the heart of Queens, and we see so much diversity amongst our patient population. And one of the things we see is high rates of atherosclerotic heart disease amongst patients of South Asian descent. This was actually recently investigated in the longitudinal cohort Masala study, which showed that South Asians have significantly higher prevalence of diabetes and metabolic abnormalities at lower body mass indices compared to other race ethnic groups. And that South Asians also had high fat deposits around the heart and body cavity, which was an independent risk factor for heart disease. Putting it all together, given this patient's presentation and risk factors, with troponin levels within normal limits, I would be worried about unstable angina.
Now, Justin, that's a great overview on how to approach this patient. And that's what the consult team was also worried about. So the patient was started on intravenous heparin and her case was discussed with the on-call interventionalist with plan for left heart catheterization the following day. It was puzzling, though, the dextrocardia seen on chest x-ray. The consult team at the time didn't really know what to make of that finding. So, David, I wanted to ask you, what is your differential for this patient with dextrocardia?
So, dextrocardia is a cardiac positional anomaly where the heart is located in the right hemithorax with its base to apex axis directed to the right. This malposition is intrinsic to the heart and is not caused by extracardiac abnormalities such as right lung hypoplasia, right lumenectomy, or diaphragmatic hernia. Dextrocardia can be associated with sinus solidus, which is a normal anatomic positioning of the atria and visceral organs, or sinus inversus, where the position of both the thoracic and abdominal viscera are reversed. One way that this can be distinguished with chest radiography is by looking at the positioning of the aortic arch and gastric bubble. In sinus inversus, aortic arch will be located in the right side of the chest and the gastric bubble in the right upper abdomen. In our patient, the aortic arch was to the left and the gastric bubble was seen in the left upper abdomen. In patients with dextrocardia, 12-lead EKG will show right axis deviation, with lead 1 frequently demonstrating a largely negative QRS complex and inverted P and T waves. QRS complexes in leads AVR and AVL are reversed so that the R wave in the AVR is positive. Another finding on EKG which can be seen is that a typical QRS complex progression is reversed, most notably in V4 to V6. This finding helps to distinguish dextrocardia from lead reversal, which shows typical R-wave progression from V1 to V6. In our patient, there was decreased R-wave progression was reversed. However, the axis was normal and lead AVR was globally negative. The differential diagnosis for dextrocardia is narrow and includes isolated dextrocardia, can also be Carpenter syndrome, and lastly, transposition of the great vessel. In our patient, given a normal anatomic position of the aortic arch and gastric bubble, Carpenter syndrome was unlikely. That leaves us with either isolated dextrocardia or transposition of the great vessels.
So she was admitted, and over the next few hours, her chest pain spontaneously started to improve and eventually resolve, along with her dyspnea. At this point, we were no longer sure about our original diagnosis of unstable angina, and given that her X-ray findings showed the dextrocardia, wondered if maybe something else was going on. Naturally, the next best diagnostic modality was a transthoracic echocardiogram. Can you tell us what the echocardiogram showed, how that changed the differential diagnosis and next steps in management?
So her echocardiogram revealed that she had a systemic right ventricle and a subpulmonic left ventricle. Her systemic right ventricular function was reduced. There were no other abnormalities, including any shunts or valvular disease, that were seen on her echocardiogram. This all but clinched our diagnosis of congenitally corrected transposition of the great vessels. We decided to get a coronary CTA, though, not only to evaluate the positioning of the great vessels, but also to rule out any obstructive coronary artery disease, which we were initially thinking about during her initial presentation. Her coronary CTA showed a calcium score of 3, L-looping of the great vessels, and non-obstructive CAD. Additionally, there was a persistent left superior vena cava, which could be seen draining into the coronary sinus.
What a case from the initial presentation to the final diagnosis. But what is congenitally corrected transposition of the great vessels?
So, congenitally corrected transposition of the great vessels is a rare structural heart disease that constitutes less than 0.5% of all congenital heart defects. While it's not definitively understood what causes the abnormal embryonic development, it's believed that it is a result of a defect in the development of the primary cardiac tube. If we go back to embryology way back from our first year of medical school, remember that the primitive heart tube is comprised of 6 regions, and from superior to inferior, they include the aortic roots, truncus arteriosus, bulbus cordis, ventricle, atrium, and sinus venosus. By day 22 to 23, the primary cardiac index forms the cardiac loop, with the bulbus cordis bending ventricle-caudally and to the right, while the primitive ventricle aspect bends dorsocranially and to the left. The bulbous cordis develops into the trabeculated parts of the right ventricle. The middle segment, also known as the conus cordis, is the precursor for the ventricular outflow tracts. The truncus arteriosus gives rise to the proximal portion of the aorta and pulmonary artery. In congenitally corrected transposition of the great arteries, the bulboventricular part of the primary cardiac tube forms a left-sided loop instead of a right-sided loop, resulting in the morphologic LV being positioned to the right of the morphologic RV and both AV and ventricular arterial discordance. As a result of this, blood flow in the cardiac system is not disturbed, despite the discordance. Deoxygenated blood flows from the correctly located right atrium to the discordant left ventricle via the mitral valve and into the lung through the pulmonary arteries. Oxygenated blood flows from the lungs through the pulmonary veins into the left atrium and then to the discordant RV via the tricuspid valve before being pumped through the aorta into the systemic circulation.
What are some of the other anomalies that can be associated with congenitally corrected transposition of the great arteries?
So most cases of congenitally corrected transposition of the great arteries, also known as CCTGA, have one or more coexisting malformations, most frequently ventricular septal defect, which can be seen in up to 80% of patients. Valvular or subvalvular pulmonary artery stenosis can also be seen in up to 40 to 50% of cases, and LVOT obstruction and or Epstein anomaly is seen up to 30% of cases. Additionally, dextrocardia, which was a finding in our patient, can be seen in up to 20% of cases.
What are some of the imaging modalities used to make the diagnosis of CCTGA?
So echocardiography remains one of our hallmarks in diagnostic imaging modalities for CCTGA. In echocardiography, we can use different landmarks to help us identify the morphologic RV and LV. The morphologic RV can be identified by its trabeculations as well as identification of the moderator band. Another thing that we can see in echocardiography for CCTGA is that in the apical forechamber, we can identify the morphologic tricuspid valve as it's more apically displaced compared to the mitral valve. Another imaging modality which we use in our case is CAT scan, specifically coronary CTA. And there are specific CAT scan findings that we can use to help us determine different structures. So left atrium can be identified by visualizing the pulmonary veins as well as the left atrial appendage, which appears more finger-like. Additionally, another clue is the relationship of the pulmonary artery with the aortic arch. And in CCTGA, the aorta is anterior and to the left of the pulmonary artery.
Thank you so much, guys, for giving us such a thorough overview of different imaging modalities and how to distinguish the morphologic LV from RV. I think it's important to point for our audience that the tricuspid valve is always associated with your right ventricle. And similarly, the mitral valve is always associated with your left ventricle. So that's how we use a tricuspid valve as a landmark for finding which one of those ventricles is your RV and LV. Because even though the atria can be swapped around or the great arteries can be swapped around, the tricuspid valve will always be with the RV, mitral valve always with the LV.
So I have found this so helpful, all the tips and tricks on how to kind of determine what structure is what. And as a first year cardiology fellow who's still kind of working on refining what is normal, this was, really, really helpful for me. I wanted to ask you guys, this might be a really basic question, but when thinking about how I'm like trying to refine finding my windows with echo, just logistically, when you're doing an echocardiogram for someone with dextrocardia, how do you usually approach that with positioning of the probe and everything?
Well, I remember when I took a look with the echo probe, that didn't cross my mind, and I put the probe in all of the normal landmarks that we use. And then one of our echo techs had to go back and do it again with their dextrocardia protocol. So it was a learning point for me.
No, definitely. I feel like the sonographers are so skilled, and I would definitely have to go back with their expertise guiding me.
Yeah, I think that's a really good question, Claire. As general cardiology fellows or, residents or anyone who's on call and maybe potentially face such a situation, I think doing what our team here did, where they went for their regular windows, maybe you notice at that point that the windows aren't looking like the way they should. I think at that point, even if you don't know what that specific dextrocardia protocol is off the top of your head, you can just kind of play around because you know at the end of the day what the image should look like. So I think you can just shift your probe and start trying to discover the right window. So shift it across the chest, find another intercostal space, maybe move towards the right of the chest a little bit. Because remember, at the end of the day, also, not all dextrocardia patients are created equal. And so I don't know if there's one specific protocol that's going to get you good images for all dextrocardia patients.
Yeah, that's a great point, Rawan. Just kind of taking a deep breath and practicing those maneuvers that we learn about sliding and tilting and finding structures that look familiar and then going from there. And I think that's key to this case because she has so many unique anatomical features to her heart. And so being able to kind of pause and break it down is key.
Yeah, and that's what I was trying to do. I was really trying to focus on how can we find structures that we know what anatomic structures they are. How do we know that the right ventricle is the right ventricle? Well, it's very trabeculated. We can often see the moderator band. How do we know which one is the mitral valve and which one's the tricuspid valve? So that was my approach or our approach to that section of the podcast.
By the time we had all this information, our patient was feeling much better and anxious to go home. How did she react when she was given her diagnosis?
Well, she took things pretty well. She didn't have a shocked reaction or anything like that. We spoke with her for a while, and she denied ever having any known childhood cardiac history. She also denied having any pregnancies or children. We also spoke to her at length about the progression of CCTGA and offered to make a follow-up appointment with an adult congenital heart disease specialist on discharge. She noted, however, that she was only going to be in the US for a couple more weeks and actually preferred to see a specialist back home in Guyana. We recommended changing her home atenolol to carvedilol for improved blood pressure management, and as her blood pressure remained elevated even with the resolution of her chest pain. Additionally, as her LFTs had improved during her hospitalization, she was started on high-intensity statin medications. She was also ultimately discharged home as well.
So that's a really interesting point that you made about her reaction to the diagnosis that was made. Because remind me again how old exactly our patient is.
She's 53.
Yeah, so you can imagine at the age of 53, after living your entire life, thinking that you're perfectly healthy and normal, and suddenly 5 decades into your life, you're being told that you were born with an abnormal heart and that it's a shocking diagnosis. And this is a very unique aspect of ACHD and ACHD care. I think this is one of the things that are being taught to people interested in the field or ACHD fellows and faculty is how to break such kind of news to adult patients. And it makes you wonder, is it harder to get a diagnosis of this sort when you're a kid and to grow up knowing that you have this disease? Or is it harder to get a diagnosis like this when you're in your 50s or 60s and have to suddenly acclimate to being labeled as someone with a congenital heart disease? And it's just something to think about.
Yeah, I think that's a great point, Rawan. And I think oftentimes when we think of congenital heart diseases, we're thinking of childhood and transitions of care where we're assuming the care of patients and families who have intimate knowledge with their pathology oftentimes. And I think in adulthood, sometimes those support structures and networks are not as strong or expansive as when we're seeing our peds patients. They might not have family support structures around them anymore in adulthood. And that also adds an additional level of complexity to approaching these diagnoses and supporting people through the news. I wanted to ask you guys, did you utilize any drawings or diagrams to help her conceptualize her anatomy? I feel like it can be so difficult to visualize even with knowledge of a normal heart's anatomy.
We actually did. I remember we used the back of my list that I was carrying around and we kind of drew out what was going on with her heart compared to what happens with like a normal heart development. And we tried to keep it as simple as possible to explain to her that this is what's going on and this is why it's important to follow about this, mostly focusing on the fact that her systemic RV, which the function had already been noticed to be reduced on her echo, is something that we were worried about. And I think she understood kind of what we were saying. And I thought we did a really good job of explaining in simplistic terms what was going on. I think she was just a very stoic woman and talking to her, it sounded like she didn't really have many health issues growing up and didn't have many doctor's appointments, didn't have any pregnancies, so hadn't had any prior interaction with the healthcare system that where this could have been discovered. And otherwise was just living her life and visiting family here in the US, and happened to have this episode of chest pain, and now her life has been turned upside down in ways.
Yeah, it sounds like you entered the discussion of the new diagnosis with such intention, and you were really thoughtful in how you were going to approach a new, potentially life altering diagnosis and not overwhelm her. Remind me, was English her first language? Or I know you said that she was visiting the state.
It actually was, yeah. We didn't need to use our video translator or phone translator, which I think in this case was really good because here in Queens, we have a lot of patients that speak many different languages and dialects, and we use translators all the time. And sometimes, especially when we're giving out a lot of information or tough news, a lot of things can be lost in translation. And so she did speak English fluently and quite well. And so she was able to understand and comprehend what we were saying. And she didn't ask a whole lot of questions, but when she did, they were, very appropriate questions that showed that she understood what was going on.
Great. Yeah, I appreciate what you said about how we should always be extra sensitive to the gaps that can happen in our communication in all settings, but especially when we're using interpreters and doing what we can to make sure that all of our patients are getting comprehensive care and having all their questions answered in full.
Yeah, absolutely. I think training in a program with such diverse population trains us to be very sensitive in these topics, be ethically aware, culturally aware of different patient populations. So we're very grateful to be in this environment.
Awesome, guys. Yeah, let's keep going.
Wow. What an awesome discussion. Getting back to our original question, David, what are some of the different presentations of CCTGA and complications?
The presentation of CCTGA as an adult can be quite variable depending on whether or not there are any associated anomalies. Patients who have no associated anomalies can remain asymptomatic until the 5th or 6th decade of life. There are even case reports of patients remaining asymptomatic until their 80s. Many patients will present with symptoms of congestive heart failure due to the progression dysfunction of the systemic right ventricle. The progression of the disease will make the RV weakened and it can dilate. It remodels and enlarges, causing tricuspid regurgitation as a sequelae. This occurs due to the inability of the systemic RV to adapt to elevated pressure. Another common presentation is tricuspid regurgitation in the aforementioned pathophysiology. It is often caused by the dilatation of the systemic RV or intrinsic anomaly of the valve, such as epsinoid leaflets, where the tricuspid valve is apically displaced, which can be seen in CCTGA. Finally, arrhythmias are also commonly seen due to abnormal positioning of the AV node and course of the AV conduction bone.
David, what are some of the challenges with the management of CCTGA?
Management of CCTGA can be challenging and patients require close follow-up. The 2018 ACC and AHA guideline for the management of adults with congenital heart disease recommend outpatient adult congenital heart disease follow-up every 12 months for patients who are physiologic class A or B, like our patient, given her reduction in systolic RV function, as well as transthoracic echocardiogram every 12 to 24 months. This can be tough for patients who may not have access to an adult congenital heart disease specialist. Medical therapy for CCTGA aimed at preservation of the systemic RV. However, there is no guideline-directed medical therapy with a proven effect on morbidity or mortality in RV dysfunction.
That's a really great point that you mentioned that I think we should just focus on for one moment here, which is medical management of systemic RV dysfunction. So if you think about your systemic LVs, which is the vast majority of patients that we see, you've got ACE, ARBs, ARNIs, beta blockers, MRAs, SGLT2 inhibitors, the list goes on and on. And it's great. And it's looking really, really bright and cheery for those patients. But then you look at systemic RV patients and, well, what do we genuinely have? And it's shocking that we've had these patients living amongst us for so long. And yet to date, we do not have any medications that actually improve morbidity or mortality. And so that's why it's not clearly written in the guidelines how to manage these patients medically. What I do want to mention, though, is that the one medication that showed some benefit in improving systemic RV function after 1 year is sacubitril/valsartan combination. So 1 year later, SRV function or systemic RV function improved based on fractional area change. They also noted improvement in New York Heart Association functional class and 6-minute walk test in those patients. But again, no significant morbidity mortality, which highlights a huge gap in knowledge that we have in this aspect of care.
I actually didn't know that about sacubitril valsartan.
Me neither.
Yeah.
Guys, that's why we're here.
Just wanted to briefly say I appreciated the point you all made about how location of our patients, where they live, it really does factor into our treatment plans and it can complicate things a lot. And just thinking about how our ACHD patients, the recommendations are for them to be seen at an ACHD center. And there are few ACHD centers, and we have a lot of patients who live rurally. And I think they've published data that suggests that half of these patients live greater than 1 hour away from ACHD centers. And so, yeah, I think just taking a step back and zooming out and thinking about our patient within the system and within their community and all of that really does factor into how we can carry our plans forward and make sure we're coming up with realistic recommendations and helping ensure that they have follow up despite all those barriers.
Yeah. And that's why when we were talking with her, we were pushing really hard to have her at least meet with an adult congenital specialist before she went back to Guyana. We are lucky here to work with a lot of great ACHD specialists from Cornell, and we were trying to get her an appointment in the next week or so, but she was pretty adamant that, go home, spend time with my family, and then I'm going to head back to Guyana. And it was tough because really the only thing that we could tell her was it's really important that you follow up with a cardiologist once you go home to keep an eye on this and see you frequently. But other than that, there wasn't really much more we could do for her. And I wish there was, but sometimes it's the unfortunate thing with these cases.
But it sounds like you empowered her with a lot of new knowledge. And I think helping patients understand how to advocate for themselves within the system is really important. And so honoring her goals of getting home and preparing her to follow up with her own cardiologist, her own doctors is really important. And it sounds like you guys did that really well.
That's amazing. So what else can you teach us about CCTGA?
So going back to other management to help slow the progression of CCTGA, the blood pressure control is crucial to slow the progression. Additionally, cardiac resynchrony therapy had been shown in a small study to improve functional status as well as improvement in RV function, but this requires more studies and investigation. Finally, tricuspid valve regurgitation is a major cause of morbidity and mortality. And actually, one study showed that a systemic atrioventricular valve surgery in patients with CCTGA led to low early mortality and improved RV function in patients with SRV EF greater than 40%. The current guidelines for the management of adult congenital heart disease recommends tricuspid valve replacement for symptomatic adults with CCTGA and severe TR with preserved or mildly depressed systemic ventricular function as class 1.
All right, guys. So I absolutely love the points that you're mentioning here. You are hitting just absolute gold with the management key points that you're bringing up. Let's break it down a little bit further. So you mentioned CRT, so cardiac resynchronization therapy, as an option for management. Now, it's important to note, though, that in CCTGA patients, it can be a little bit tricky to put in a CRT device because accessing the coronary sinus with the degree of congenital anomalies that they have can be a little bit challenging, to say the least. And so what I want to add to that is that recently, our brilliant electrophysiology colleagues have been looking at the option of left bundle pacing as a modality of providing physiologic pacing, which, if you think about it, is actually super duper easy in these patients because the LV, where the left bundle is actually the venous ventricle, correct? And so if you go in through the natural process where you go in to put in a CRT through the venous system, you go through your SVC, IVC, you end up in your left ventricle in a CCTGA patient. And so all you have to do is just stick a little lead right into the left bundle that's looking straight at you, and you're done. Again, this is very new. We don't know if this improves mortality in the long run, and obviously more studies need to be done, but it's a new thing that's happening, and we should all be looking out for some awesome results. The other great thing that you mentioned is the tricuspid valve replacement or systemic AV valve replacement. And I think that we should point out this is probably one of the most controversial topics in ACHD, hands down. And it's for a number of reasons. So if we break it down to like the two key reasons as to why this is controversial is first, there's always a question of chicken or the egg. So is the tricuspid valve anatomically abnormal, causing systemic RV to fail? Or is a systemic RV dilating over time, causing dilation of the tricuspid valve annulus and causing tricuspid regurgitation? And you kind of brushed on this earlier on. And so not having a good understanding of the pathophysiology of the disease makes people hesitant to take patients in to perform high-risk surgery. The other thing that I wanted to point out that leads to this controversy is that the vast majority of studies that were done to look at the benefit or impact of tricuspid valve replacement in these patients are very, very small studies looking at 10, 20, 30 patients at a time. And when it started off earlier in the 1980s, 1990s, they just saw incredibly high mortality rate, up in the 20, 25% in the early postoperative period. Obviously, when that happened, everyone backed off. Physicians were like, nope, we don't want a quarter of our patients to die right after having a surgery, so it's not worth it. So that idea of tricuspid valve replacement died with that. But over the next 2 decades, some courageous physicians came out and were like, no, we think that there is some potential benefit here. And so they started to do small studies again and again. And what they started to show is that patients reported improved functional status. Their New York Heart Association class improved. Their quality of life improved, which was good, right? We want our patients to feel better. And then eventually, over time, they realized when they looked at the early post-op mortality, the mortality rates were no longer 25%. As a matter of fact, there was one study that reported 0% mortality in the early post-operative period. And whether that's because we're doing so great as physicians from an anesthesia perspective, or whether our experience is making us so much better from a surgical perspective, we don't really know. But what we know is we are actually doing better. And so with that, people started to explore this area a little bit more. And I'm going to just mention this briefly and can't really talk about the data too much, but I will say that there is a very big study, the largest study looking at CCTGA and ACTGA patients, but we're looking at the benefits of tricuspid valve surgery in TGA patients with systemic RVs. We're looking at 140 patients here. Okay, so the biggest study ever. And it was done as a collaboration between the Alliance for Adult Research in Congenital Cardiology in North America and the European Major Adverse Ventricular Arrhythmias and Related Effects group in Europe. And these great centers collaborated to try to find out once and for all, is it beneficial or not? And the outcome they looked at was effect on death, transplant, and mechanical circulatory support need. And all I'm going to say is keep your eyes out because the manuscript is coming out soon, hopefully, and we will all find out if there's something incredibly exciting in the field of ACHD that is going to change our management and potentially our guidelines. And that's all I'm going to say.
Yeah, no, reading about some of the different complications, I think makes sense how high percentage of these patients end up with some sort of tricuspid valve dysfunction and how that really drives a lot of the morbidity and mortality of these patients.
Absolutely. Yeah. It's a really hard topic, especially CCTGA patients having so many innate tricuspid valve abnormalities, because some reports actually say up to like 80% of these patients or 70% of these patients have abnormal tricuspid valves. It's so hard to say, should I fix the valve and that will fix the RV, or is it just a sequelae of the RV malfunctioning? It's a really hard part of ACHD, guys.
Finally, arrhythmias are also commonly seen due to abnormal positioning of the AV node and course of the AV conduction. Approximately 10% of the patients with CCTGA initially present with complete AV block. The risk of developing AV blocks is about 2% a year.
And that is a cumulative risk. So you can imagine by the time someone with CCTGA is 50, the chance of them having complete heart block is quite high. And here's a fun tidbit for you. Some CCTGA patients are actually born with 2 AV nodes, not 1. But unfortunately, neither one is really doing its job right.
Oh, yeah.
That's amazing.
Yeah, I think we all want to do adult congenital now.
My plan is working. So, all in all, guys, this has been an incredibly insightful and very educational discussion. Do you mind giving us just, your favorite pearls or learning points from today's episode?
Absolutely. So, pearl number one, CCTGA is a rare and unique structural heart disease, which presents as an isolated combination of atrioventricular and ventricular arterial discordance, which results in physiologically corrected blood flow.
Then takeaway two, CCTGA presents as L looping of the embryologic heart tube. In L looping, the morphologic right ventricle supports the systemic circulation and the left ventricle supports the pulmonary circulation.
Pearl number three, CCTGA is often associated with VSD around 70% of the time, pulmonic stenosis 30 to 50%, tricuspid valve abnormalities 30%, and dextrocardia around 20%.
Pearl 4, CCTGA is often asymptomatic in childhood, but can present later in adulthood with symptoms such as systemic right ventricular failure, tricuspid regurgitation, or cardiac arrhythmias like complete heart block.
Our final takeaway, systemic atrioventricular valve intervention can be a valuable option for treating RV failure and degeneration of the morphologic tricuspid valve.
Wow, team, this has been an absolutely incredible discussion. I learned so much from discussing your patient's case, seeing how you walk through the patient's anatomy, from embryologic development to how her anatomy looks like now on imaging as an adult. We talked about the diagnostic modalities. We talked about management of CCTGA patients, and especially challenges in management of CCTGA patients when it comes to medical therapies or surgical intervention. And we touched on some really good points as well when it comes to challenges faced in terms of access to care with ACHD patients in general. So, all in all, I think we had a fantastic conversation and have a thorough understanding now of CCTGA patients and are ready to tackle on our next case that rolls in through our ED doors.
And another reflection I have from this case is just how humbling cardiology can be and how there's just always surprises in our line of work. And just thinking about how initially we're working up this patient for ACS, kind of a bread and butter picture initially, and then bam, a chest x-ray shows the heart's in the wrong direction. And it just kind of opened up into this really interesting, complex case that you guys led us through so masterfully. And yeah, I learned so much, and I'm really glad that I could be here for this segment. And we like to close out our episodes by asking our guests what made their heart flutter this week. I know that having this opportunity to learn with you guys certainly made my heart flutter. But do you have any reflections on what has made your heart flutter in this patient case or in patient care in general with cardiology?
I think one thing that makes my heart flutter is we just have a great group of individuals that we get to work in on a day in, day out basis, from my co-fellows to the staff in the echo lab, the cath lab, our cardiac ICU. Now, it really makes it enjoyable to come to work and tackle challenging cases with these guys and girls. I've had the absolute pleasure of learning so much from them over the past 6 and 7 months of my first year of fellowship. And so that's something that always makes my heart flutter coming to work.
I guess I was in the cath lab on elective when Wang actually called in about this patient originally. And that definitely made my heart flutter. Rawan, I know you mentioned going into congenital disease specialties with intervention. And I guess in this episode, makes my heart flutter a little bit as well. So colored me interested.
And lastly, I would like to thank my co-fellow Oyen for giving us the opportunity to be in this podcast. That makes my heart flutter. We learned a lot. I'm thankful for the opportunity to be in such great presence, to learn. And as Claire mentioned, I think cardiology is definitely humbling. There's just so much to learn, so much that we do not know. And the more that we learn, the more that we learn how much we do not know. And I'm just grateful to be here.
Thanks, guys. You guys made a great team, and it sounds like we have some ACHD converts, Rawan.
My goal has been achieved.
And now for the expert commentary and review segment of this episode, I'd like to introduce Dr. Yuan, an adult congenital heart disease specialist at NewYork-Presbyterian Cornell. We get the opportunity to rotate through the congenital service at Cornell during our fellowship. And, many of our fellows have said that they've learned a lot from Dr. Yuan about adult congenital heart disease and echocardiography. So I'm honored to introduce her to this podcast.
Thank you so much, the CardioNerds team, for inviting me here today. What a fascinating case our NYP Queens fellows have brought to discuss. So thank you as well. My name is Yuan. I'm one of the adult congenital cardiology specialists at NYP Cornell, and I do both clinical cardiology as well as cardiography. My colleague is Dr. Harsimran Singh, who is also congenital cardiology, obviously, but more interventional procedures. CCTGA is indeed one of the rare forms of congenital heart disease. And when we think about patients with systemic right ventricle, we're really talking about those with CCTGA or those who were born with DTGA, detransposition of the great arteries, who underwent atrial switch procedure. In these patients, the right side of right ventricle is connected to the aorta and the left side of left ventricle is connected to the pulmonary artery, where atrial baffles are used to direct the venous blood return back to the heart. So the blood flow is in continuity within the circulation, as opposed to in parallel, as it had been at birth. Comparatively, for patients with CCTGA, as our fellows have discussed in excellent detail, the blood flow is actually correct. However, the left-sided ventricle pumping to the aorta is the morphologic right ventricle, as opposed to normally the morphologic left ventricle. And this means that the left ventricle is actually right-sided and pumping to the pulmonary circulation. It is interesting that this patient also had a left SVC to the coronary sinus, which actually is a benign and quite commonly seen malformation in patients with congenital heart disease. Of course, we do see this on imaging demonstrated by a dilated coronary sinus, even, for example, in transthoracic imaging. And usually this is of no or minimal importance, other than, for example, for our electrophysiology colleagues at the time of pacemaker implantation. In terms of chest pain and congenital heart disease, there's a few different reasons why our patients may have this. Of course, all of our patients can develop cardiovascular risk factors over the lifetime, and then also develop acquired heart disease as well. The other more congenital reason for chest pain can include coronary abnormalities. In this case, in any case of abnormal arrangement of the great vessels, we know that there's rotation of the aortic cusps and therefore origins of the coronary arteries. Additionally, we see that there can be abnormal coronary development where the origin and then the pathway of the coronaries can be abnormal, or sometimes we can also see a single coronary artery supplying the entire myocardium. In patients with CCTGA, the typical arrangement is that the left coronary comes off the right-sided cusp and the right coronary artery originates from the left-sided cusp. Over time, of course, with RV hypertrophy, possibly dilation dysfunction, this can set up relative ischemia and more anginal symptoms as the single right coronary artery is supplying the dominant ventricle. Dextrocardia itself is a rare presentation overall with unknown exact incidence. Some numbers that are suggested is somewhere around 1 per 12,000 pregnancies. In the case of CCTGA, dextrocardia is slightly more commonly found. What is most important about the patient with dextrocardia is really identifying the arrangement of the thoracic and abdominal structures, as dextrocardia can be associated with inversions or reversed arrangement left-right, or even sinus ambiguous, where there's actually a duplication of the atrial arrangement, and that conveys differences in terms of the thoracic organ arrangement, and then also abdominal structures as well. Finally, dextrocardia can also be seen in complex congenital heart disease, such as single ventricular physiology, where there's absent atrioventricular connection, or, for example, both AV valves enter into or connect to the left ventricle, and then other cardiac diagnoses as well. The EKG in dextrocardia is incredibly well described by our fellows, so thank you very much. I would also say that ECGs in general are a very important diagnostic tool as part of the routine follow-up for all patients with congenital heart disease, where I do at least an annual ECG. This, of course, is screening for progressive conduction disease. In our CCTGA patients, of course, we're looking for complete heart block. but also generally looking for example, arrhythmia burden. In terms of CCTGA itself, there is division between simple versus complex CCTGA, where complex CCTGA includes patients with not only CCTGA itself, but also VSD, pulmonary stenosis, and the emptying tricuspid valve. In terms of this diagnosis, beyond just what we typically think of an abstenoid valve that is apically displaced compared to normal, what really this means is that the valve itself is dysplastic. When we think about reasons for why there's tricuspid regurgitation or RV dysfunction in the patient with CCTGA, this would be one reason for primary valve dysfunction that likely is an inciting event that starts the negative spiral that causes earlier RV dysfunction for the patient with CCTGA. Comparatively, patients with simple CCTGA, so without any other associated lesion, of course, this can actually be quite well tolerated through the lifetime, and patients may be incidentally found in their 6th, 7th, or even 8th decade of life, as mentioned in the podcast. The other thing I want to highlight here is that sometimes there is thought that mild to moderate LVOT stenosis or pulmonary stenosis can be physiologically helpful in the patient with CCTGA by limiting septal shift of the RV into the LV. So normally the RV is crescentic, but in the patient with systemic right ventricle, it takes on more of a cylindrical shape, similar to a normal left ventricle. This, of course, then allows RV dilation and then tricuspid regurgitation and then progressive RV dysfunction is the thought. Whereas when there is LVOT or pulmonary stenosis, the septal shift is limited. And so there's less deformation and dilation of the annulus, less tricuspid regurgitation, and delay of RV dysfunction. It's something that we didn't touch on prior in the podcast is this idea of physiologic versus anatomic repair for patients with CCTGA. For a period, there was great enthusiasm for an idea where instead of leaving the right ventricle as the right ventricle, of actually creating surgical repairs to bring the left ventricle in connection with the aorta such that the systemic ventricle is the left ventricle. Even for patients with CCTGA, usually more complex CCTGA, unfortunately, there are some complications here too because of the complexity of the surgical repair that's required in order to do this. And comparatively, usually now, we leave patients with what's called physiologic repair, meaning we leave the RV as the systemic right ventricle in connection with the aorta. I really enjoyed the fellows' discussion of imaging for the patient with CCTGA and their experience at the bedside completing the transthoracic echo. Usually what I recommend or kind of counsel our fellows is taking a segmental approach when assessing anatomy for any patient with congenital heart disease, meaning imagine yourself as a red blood cell. How are you traveling through this heart and where are you ending up? And then along the way, making sure that you've identified where each structure that you normally would expect is found and how it is in relation to the other structures. So in this case, what are the venous connections coming back to the heart? Where are the atria located, the left versus the right morphologic atrium? Where are the AV valves? And they do in fact go with the ventricle as discussed. The tricuspid goes with the right ventricle and the mitral valve goes with the left ventricle. Where in relative space are the right and left ventricles located? And then also where are the semilunar valves, which also go with the great vessel? So the aortic valve goes with the aorta and the pulmonary artery has the pulmonary valve. And in a lot of congenital heart diseases, including CCTGA, a striking feature is that the great vessels are in parallel as compared to the usual spiral relationship. And this can be sometimes an easy clue or first clue that in fact the patient has congenital heart disease when you see this present in their imaging. I also really enjoy the fellows' discussion of what the morphologic features are of some of these structures that would differentiate them from the other structures. So for example, in the case of the right ventricle, finding the moderator band, the more coarsely trabeculated RV body, the fact that the tricuspid valve is more apically displaced, there aren't just well-localized, identifiable papillary muscles, as there are the two for the mitral valve on the left side. And then compare this with the left ventricle, which is usually much smoother without the moderator band. Similarly, for the atria, usually how we describe the morphologic atrium is based on the structure and coarseness of the pectinate muscles in the atrium themselves, and then also looking at the shape and morphology of the atrial appendage. And the other trick that I offer our fellows is when you're imaging congenital heart disease, sometimes what can be helpful is to take long 20-beat, for example, sweep through the heart in anterior-posterior or left-right orientation to really highlight the structures that you're seeing and identifying the relationship to one another in space. The other option, too, is to make sure that you label where the indicator of the probe is so that you don't get lost. As sometimes when you flip the probe without indicating on a screen, it makes it look as though the structures that are left-sided are now right-sided or vice versa. That can be quite confusing for the reader or when you come back to the images themselves. It is true that the RV function in terms of follow-up can be quite challenging because we're depending on factors such as CAPC, RV prime, fractional area of change, and longitudinal strain, which is probably of these parameters that is slightly less commonly used. I would say that the gold standard that we use in terms of assessment of RV function for the systemic RV over time is really cardiac MRI. This gives us great volumetric data, as well as quantification of ejection fraction, and then assessment of fibrosis scar burden by late gadolinium enhancement. There's also kind of more recent data suggesting that RV volume by MRI data can be helpful for risk stratification in terms of survival, essentially a composite outcome over about 8 years of follow-up based on heart failure referral, VAD, or death. And the cutoff in terms of differentiation between survival versus not for patients with systemic RV, including both those with TGA, status post-atrial switch, or patients with CCTGA, was around 130 mils per meter squared for index RV and diastolic volume, which I thought was quite interesting. And hopefully we'll have more of this data to follow. The other parameter that can be important, kind of based on more recent data, is looking at RV longitudinal strain, where there seems to be some data from the Mayo where a longitudinal strain less than negative 16% before systemic tricuspid valve replacement seemed to be associated with improvement in exercise capacity and can be helpful in terms of our selection of patients and timing of tricuspid valve replacement for CCTGA patients. I also really enjoyed our fellows' discussion of medical therapy in the systemic right ventricle because, unfortunately, the data is somewhat mixed. We have a handful of randomized controlled trials with more modest outcomes and disappointing data compared to cohort studies, both retrospective and prospective, that demonstrated possible benefit. In this case, looking at, for example, data for ARNI and then also SGLT2 inhibitors, both dapagliflozin and dapagliflozin at about 6 to 7 month follow-up, where there seems to be some reduction in NT-proBNP values, improvement in subjective symptoms by NYHA class, and then also improvement in 6-minute walk test or heart failure emissions. So hopefully we'll be able to find more information to support the use of these agents and stronger outcomes benefit for our patients as well with the systemic right ventricle. I also really enjoyed our fellows' discussion of indications around tricuspid valve replacement for patients with CCTGA. It is true that the current 2018 guidelines recommend, with Class 1 recommendation, valve replacement in patients with severe symptomatic tricuspid valve regurgitation and relatively preserved RV function, essentially RV ejection fraction over 40%, compared to a Class 2A recommendation for tricuspid valve replacement in patients with severe TR who are asymptomatic and relatively preserved RV function. One thing I caution here is that oftentimes our patients with congenital heart disease underestimate their functional ability. Whereas they feel unlimited or only report mild symptoms, we comparatively see much more marked reduction in their objective exercise capacity on testing such as cardiopulmonary exercise studies. And so here I want to highlight the importance of longitudinal routine screening or follow-up with objective testing to ensure that we don't miss that threshold of benefit for our patients as well. There is some demonstrated benefit in terms of CRT therapy for patients with systemic right ventricle, in terms of improvements in NYHA functional class, as well as small improvements in RV ejection fraction in selected patients as well. The last 2014 Heart Rhythm Society statement had offered class 2A or 2B recommendations for CR in patients with systemic right ventricle based on NYHA functional class, as well as RV function, based on ejection fraction greater than 35% or less than equal to 35%, and then also QRS duration. They also offered a class 2B recommendation for CRT therapy in patients with reduced RV function, RVEF less than or equal to 35%, who are ventricular pacing dependent, so who have more than 40% ventricular pacing post-implantation as a way of trying to prevent pacing-induced ventricular dysfunction. And as Rawan has mentioned, there is interest in finding alternative strategies for more physiologic pacing and identification of the true cohort of benefit for our patients here. One final thing I want to come back to is their really heartfelt discussion about breaking new diagnoses to adults in terms of congenital heart disease. I think it's challenging probably at any age in terms of finding out about a new diagnosis or to have known it from an early age. A lot of our patients with congenital heart disease experience anxiety and mood disorders, and probably a lot of that stems from their childhood interactions with the healthcare system, and probably some of it is really PTSD, and certainly something that I think all programs need more access to, our social workers and healthcare professionals, to be able to support our patients more completely. Finally, I always emphasize to our fellows that our congenital heart disease patients end up traveling down the dual pathways of arrhythmia and heart failure. Just as follow requires multimodality imaging and assessment, our patients' care also requires collaboration between subspecialties such as electrophysiology and heart failure. The good news is that generally, though congenital heart disease patients have shown higher early mortality post-transplant within 30 days and up to 1 year, they have better long-term survival compared to patients with acquired heart disease who undergo transplant. Alternatively, it is true that end-of-life planning and palliative care are equally important for our patients as they experience increasing morbidity from their heart disease, which can be challenging for themselves and also for their family members too. I feel very privileged to work in congenital heart disease, where I get to take care of patients over their lifetime with such interesting diagnoses and opportunities for collaboration with my colleagues as well. Overall, this was such a great discussion, and I really thank everybody for their input today.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Julia Marques. I am an intern in the CardioNerds Academy House Thomas, and I'm a 6th-year medical student at Albert Einstein University in São Paulo, Brazil. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.